welcome everyone to our monthly Dunlevie seminar. Just to give a few center updates for the 2026 SMFM annual meeting. We had a really great outcome of 15 of our abstracts will be presented with an acceptance rate of over 80%. So kudos to all the faculty who submitted abstracts on this great outcome. The Stanford Medicine 23rd Annual Community Health Symposium went very well. Congratulations to our PRISM NIH Center of Excellence team for presenting at this symposium. And the PRISM Community Engagement and Partnership component presented a poster on community engaged methods for building a maternal health research center of excellence. And our own Dr. Irog Binosa spoke on the One Table, Many Voices panel discussion and Q&A session. So congratulations on this participation. And a special congratulations to our Dunlevie Center investigator, Dr. Matteo Mole, who was awarded a California Institute for Regenerative Medicine grant. He received $2.3 million in funding for his project, dissecting the cellular and molecular interactions established between human embryo and maternal endometrium at implantation. The proposal received a top score of 90. The selection process was exceptionally competitive with an unprecedented 372 applicants for only 23 funded projects. So incredible achievement. Congratulations, Matteo. We are so proud of you. Our next center meeting is on November 13th, and we will be having Dr. Nathan Fox, who's a clinical professor in the Department of OBGYN at the Icahn School of Medicine at Mount Sinai, and he will be talking to us about delivery of twins. But today we are so honored to have Dr. Anthony Odibo, professor and chair from the Department of Obstetrics and Gynecology at University Health, University of Missouri, Kansas City, who will be speaking to us on controversies in the management of fetal growth restriction. I am going to have Dr. Yair Blumenfeld introduce our honored speaker today.
Yeah, thank you, Oscar, and thank you so much, Tony, for joining us. I think looking at the people on the Zoom, obviously you chatted with Yoel, but I'm assuming, and I know that there are other people on this call who either trained with you or that you trained or you've mentored along the way. And so it's really, we always say it's an honor and a privilege, but this is just a lot of fun for me to be able to introduce you in this way, in this forum. I think when we set up the the lectureship series, this is the kind of talk we wanted to have, and to have a forum and a venue for this. So thank you for taking the time from your very, very busy schedule. So for people who aren't familiar with Dr. Anthony Odibo, who, as Yasser said, is now the department chair at the University of Missouri, Kansas, Dr. Odibo has had, simply an illustrious career in prenatal diagnosis and including in clinical obstetrics. He's currently in Kansas, but he's originally from Nigeria, trained in the UK, then came to the US and spent time in several places, including UPenn and Philadelphia and WashU and South Florida, and now back to Kansas, several places in Kansas, and was involved not only in many seminal papers related to prenatal diagnosis, but even clinical obstetrics. So a lot of the papers that people are familiar with that came out of WashU related to clinical obstetrics, Tony was an integral part of those teams. He's truly an incredibly gifted clinician and researcher, again, with a primary focus on prenatal diagnosis. Over 300 manuscripts, book chapters, editorials. He's the editor-in-chief of the White Journal, the Journal of Obstetrics and Gynecology, a preeminent prenatal diagnosis journal, on the editorial board of many other journals, and really an incredible incredible person. So really, Tony, thank you so much today. We picked this topic for you because you've spent a lot of time thinking about this topic, both individually and on an epidemiological level. And we're really, really looking forward to hearing what you have to say on this. And I'm here with my antepartum team, and we have a whole bunch of FGRs on our service now. So we're hoping you can help us manage these pregnancies that we just don't know what to do with. So thank you, Tony. And again, really, really appreciate you spending time with us.
Thank you so much. Yeah, you can hear me, and I don't know if I need to reshare my slides again or.
Yes, if you could share your screen.
Okay. Let's see. All right. Can you see the screen or?
Looks perfect.
Okay. Thank you again, yeah, and thank you to the organizers for for inviting me. It's nice to see old friends, and even Sodowski was my mentor, actually, is my division chief when I came to WashU. So it's nice to see a lot of friends on this panel today. So my goal was to spend the next few minutes talking about some of the controversies in the diagnosis and management of fetal growth restriction. And I have a lot to cover, so I'm going to rush through some. It's not because I'm nervous, it's just so that we can get time to discuss a little bit at the end, okay? So I'm going to look at the significance of fetal growth restriction, the controversies in definition, and then using what kind of growth standards should we use in the diagnosis of fetal growth restriction. And then when it comes to management, what Doppler should we use? What's the role of biophysical profile? And then a little bit about timing of delivery. So it's quite a lot to go through, but this is a significant subject because we know that the size of the fetus is pretty important. And this study shows here that the smaller the fetus is, the higher the risk of perinatal morbidity and mortality per thousand. As you start getting less than 2.5 percentile for gestational age, then the risk of perinatal death really increases almost 100-fold. Now, the incidence, sorry, let me move this. The incidence of fetal growth restriction is defined severally depending on what you use in between 5 to 10%. But we know also that as the baby gets less than 1,500 grams, the risk of perinatal death can be about 100-fold. So the controversies I'm going to cover are listed below. But first of all, going through the definition of fetal growth restriction. How do we define FGR? Ideally, the ideal definition should be a fetus that fails to meet its growth potential. But because it's difficult for us to really attribute or evaluate the growth potential of every individual fetus, we've kind of used surrogate markers such as EFW less than the 10 percentile. In the old days, people used a definition of low birth weight less than 2,500 grams. And then there are terminologies such as small for gestational age, intrauterine growth restriction, or low birth weight, or fetal growth restriction. As we all know, the last SMFM document does say we should just stick to using the word fetal growth restriction, and we'll come back to that. But in Europe, most people still argue that most of what we in the US call fetal growth restriction, they think is small for gestational age. First of all, how do we make the diagnosis? There are so many growth charts that are out there. Hadlock, which was designed from Texas about in the 1980s. Then more recently, the NICHD race-specific growth charts. Then most people talked about looking at international growth charts using the Intergrowth or the WHO charts. For many years, many of us were also interested in using customization, where you take both the maternal height and maternal race and ethnicity into consideration. And then the most significant contribution to the controversy is the Delphi criteria that is highly used in Europe currently. And we'll touch on most of these. The the real intent of most of the international charts that are out there is to see if we can find one way of unifying a growth chart that can be used anywhere in the world. These goals were very ambitious, such as the Intergrowth Group and the WHO Group. But we know that they all have both advantages and disadvantages. I like quoting this study from Dr. Blue here, which says that they compare the Hadlock chart with the NICHG chart, which is the most recent kid on the block, and found really the conclusion here was that the Hadlock chart was still better in predicting fetal growth restriction compared with the race-specific growth, despite the fact that this chart has been in existence for almost 40 years now. So no matter how we've tried to refine this, it doesn't look like we're getting anywhere. Our group compared the intergrowth study and intergrowth chart with Hadlock and also came to the same conclusion that the Hadlock appears to be more sensitive and with better specificity compared with the intergrowth study. So the Eastward guideline, which came out a few years back now, is based on some studies that were done in Europe, which I'll talk about later on. And one of the distinction here is a distinguished growth restriction into two groups, the early growth restriction and the late growth restriction. And the definitions are listed here, and I don't want to go through them individually, but you can see the use not just the EFW and the abdominal circumference, but they also use Doppler parameters, including umbilical artery Dopplers, as well as uterine artery Dopplers. And then later on in pregnancy, they use the CPR, which is the cerebroplacental ratio, in categorizing this. So it's a very complex system where you almost have to have this table in front of you each time you evaluate a fetus to say, is this growth restricted or not, or does it meet the ISWAL guideline criteria or not? And how did they come to that, to this criteria? It was really using a procedure which is called the Delphi procedure. And for those who don't know, the Delphi procedure really is almost a survey of experts, and it goes through different rounds, different renditions of refining the survey and coming to a conclusion at the end of the day on which criteria the experts agree on. So it's very important. I make this point to my fellows and residents all the time that the bottom line is the Delphi criteria is based on expert opinion. And so the level of evidence, if you're looking at it epidemiologically, is not as strong as most people would think. I do have a lot of colleagues in Europe who have very strong opinion, and they were part of the Delphi process that published the ISWAL guidelines eventually. So they swear by this, that it's the best thing that's happened to fetal growth restriction, but we know that it's not the case. So we tried to validate this many years ago. This was one of my fellows from Brazil that was visiting us in Florida. We looked at it. Yes, the sensitivity was not that great, but was at least comparable to most of the criteria we have here. And it was actually more specific than Hadlock and most of the other charts that we use. However, when you look at outcome, neonatal outcome, you can see the very ugly receiver operator curve on my right-hand side. It shows that it's not as good at predicting the neonatal outcome. So even though it reduces the number of false positive diagnoses for fetal growth restriction, it does not pick up most of the babies that end up in NICU or with some of the early neonatal morbidity that we're interested in. So what about the SMFM definition? So basically, SMFM recommends that we use either the EFW or the AC less than the 10th percentile, and they recommend using population growth chart, such as the Hadlock. They did not come out specifically to say we should use Hadlock, but something similar to Hadlock is acceptable. And they also felt that if you make an early diagnosis of fetal growth restriction less than 32 weeks, then you should do a detailed ultrasound to rule out any abnormality. So most of our fellows and most of the residents know all of the SMFM criteria. I'll come back to that later on. So once we've made the diagnosis, the question then becomes, how do we manage? And again, regarding management, there are some controversies that we'll talk about. Most of the other things, like treating any underlying maternal conditions such as high blood pressure, stopping substance use disorders, role of nutrition is always arguable. There is a study that's out there that was recently published by Greg DeVore suggesting that bed rest in pregnancy could improve growth of the fetus, but this was during the pregnancy. It wasn't after delivery to see if there was any improvement in growth. So that should be taken with some caution. Now, antenatal testing and timing of delivery, that's where we have a lot of controversy. So the goal of management, obviously, is when we're trying to balance the risk of fetal deaths versus neonatal death. If we deliver them too early, they will die in the NICU. So what do? We do the non-stress test, and we know that the non-stress test has sensitivity that's highly variable. And for this reason, if you look at the Cochrane database, there's really no review that's endorsed the non-stress test for managing even these high-risk conditions. And the specificity is not very good. So for when we have an abnormal test, we tend to look for other tests such as the biophysical profile to refine the findings from NSTs, right? The group in Europe also use a computerized CTG, which is the same thing as non-stress test, but it's interpreted by the computer. And the advantage is that it looks at the short-term variability or short-term variation, which you cannot detect by human eye. So that's one of the advantages. The problem is that it's an expensive tool, and there are not too many studies that are out there that have actually endorsed the use of the computerized CTG. The Truffle trial, which was published quite a few years ago, endorsed the use of computerized CTG in managing fetal growth restriction. And this was a conclusion by Roberto Romero in a review that he published accompanying the Truffle trial that was suggesting that the CTG, when interpreted by a computerized method, can be useful. I looked at this, looking at the Cochrane database evidence from about 2015. I think that was the last review that looked at computerized CTG. Yes, there is some evidence that it can prevent perinatal mortality. However, if you see the analysis on my right, it shows that when you look at preventable perinatal mortality, the computerized CTG may not be as useful as we think. The problem, though, is that there are only 3 studies that are randomized trial that could be looked at for these 2 outcomes. So there's still limited data on computerized CTG. And for reasons that we don't know, it hasn't really caught on here in the United States. And I think there was a group even from Pittsburgh many, many years ago that tried to look at this. And Tony Vinciliosi's group also tried to look at computerized CTG, but I'm not aware of any other group in the US that have investigated this or are using computerized CTG. So it may not apply to our situation here in the US. So because of the false positive rate with NST, people will fall back on using the biophysical profile. Mark you, the SMFM document does not come out to endorse the biophysical profile, partly because they felt that by the time the biophysical profile becomes abnormal, that most people would have had other reasons to deliver these fetuses that are growth restricted. But it does have a sensitivity of about 67% and specificity of 82%. Most of these were from large observational studies, and they were not really they were not randomized control trials. So that's why if you look at the Cochrane database as well, it does not have any study on biophysical profile to endorse biophysical profile. This is a review that was done by Ahmad Bashat and colleagues many years ago, again, trying to address this controversy on whether we should use BPP in making decisions with growth restriction. And it does show, though, that as you get to an abnormal BPP that's less than 4, there's a strong association with a low pH less than 7.25. So there's definitely a high positive predictive value once you start getting to those low values. And when you get to a BPP of 2 or below, you get almost 100% positive predictive value of a poor outcome. So I don't think we should throw away the biophysical profile. And I think for most of our units, including ours here in KC, we still use the biophysical profile in monitoring these fetuses. What about Dopplers? It's interesting that before 1996, ACOG and many of the governing bodies here in the US thought the Dopplers, including umbilical artery Doppler, was investigational. It's only after 1996 that they started looking at umbilical artery Doppler as a possibly accepted tool for managing fetal growth restriction. So these are some of the Dopplers that people have looked at, not just the umbilical artery, but we talked about uterine artery, which we don't look at here, but is used in the UK and Europe. Ductus venosus, again, the SMFM document does not recommend it, but in Europe it is used, especially in early onset growth restriction. And then the middle cerebral artery, and then the new thing on block is the cerebral-placenta ratio, which we'll talk about in a minute. So umbilical artery Doppler has gone through a lot of scrutiny compared with many of these other newer Doppler indices. So this is a Cochrane review showing that they've evaluated over 10,000 pregnancies using umbilical artery Dopplers from about 15 to 16 different trials. And there is strong evidence that umbilical artery Doppler can reduce perinatal death and perinatal mortality in high-risk pregnancies, not low-risk pregnancies. So I will not go into the individual analysis here, but most of these are very old studies, but they definitely prove the role of umbilical artery Doppler, and that's why it's endorsed by everybody, including the SMFM and most of the authorities in the US. Now, the MCA, for many years, we were using the MCA as a way of evaluating growth-restricted fetuses, more from understanding the physiology of how things get worse and the brain-sparing effect. But we know that as the resistance starts increasing in the MCA, then it could be a poor sign. And we used to call that a sign of losing its cephalization, and there could be a pre-morbid evidence. But because MCA on its own hasn't really caught on, the Europeans came up with an index, which is the cerebral-placenta ratio. But it's not really a new index because it was first described in the 1980s. Basically, it's dividing the MCA PI by the umbilical artery PI. And it does capture the redistribution of blood, both in the brain as well as the increased resistance to blood flow that's occurring at the level of the placenta. So I think that's, in theory, the beauty of it. There are many ways where this has been described and has been used, and different definitions. Most people will use either a ratio less than 1 or less than the 5th percentile. Many years ago, we looked at this 2005 when I was at Penn, and we talked about a ratio of less than 1.08, which is very close to less than 1. So if you use less than 1, that's fine. Now, the sensitivity of the CPR for predicting adverse outcomes, again, goes from about 66 to about 85%. And most of the time, the specificity that's been reported has been acceptable for most cases. The question becomes, how do you use it to manage growth-restricted fetuses? The results of the Truffle trial, when they did a secondary analysis using CPL, show that it may be of benefit more in late pregnancy than in early pregnancy. So some group from Barcelona collaborating with Grataco's group and collaborating with international groups from South America tried to use this as a way of just predicting delivery or timing delivery of fetal growth restriction. This is a multi-center trial that was published about just 2 years ago. It's called the Ratio 37 study. And basically, it did not show a usefulness for cerebroplacenta ratio at term because it was not associated with reduction of perinatal mortality compared with if you don't use, if you use just the umbilical artery Doppler only. And it does show a significant reduction in some of the early neonatal morbidity, but not perinatal mortality. So there is still some question of how do we use CPR? My thought really is that the CPR can be of value when added to the umbilical artery Doppler, but we're still not sure about the group to use this on. There is a study that's going on in Europe now, which is the Truffle 2, which is going as a randomized trial where they're using, instead of calling it CPR, it's called the UCR. Basically, it's dividing the umbilical artery PI by the MCA PI. Basically, it's the same thing. Our group and others have shown that flipping the ratio does not really change the outcome, but this was how they got the funding in Europe. So that study is recruiting heavily, and they hopefully in a year or two should be completed to see whether the CPR adds some value in timing delivery of growth restriction at term. Now, uterine artery Dopplers mentioned the Delphi criteria and the ISUO guideline does suggest using it, but this is not really based on strong evidence, so I'm not going to go too much into that. The SMFM document does not recommend the use of uterine artery Doppler. Ductus venosus also got a lot of attention many years ago. And again, for most people who do ultrasound, you know how the ductus venosus works. You can report it either qualitatively or quantitatively. Most of us just use the qualitative absence of the A wave as an abnormal ductus venosus Doppler. We've at least don't use it in management of growth restriction here in the States, and the SMFM document does not endorse it. But the ISUO guideline and most European studies show that it could be useful in early pregnancy or early growth restriction between 26 weeks and 32 weeks gestational age. Again, there still needs to be maybe more studies looking at the use of ductus venosus at that time period, at least to validate what's been claimed by some of the studies from Europe. So we know about the SMFM guideline, and we've talked about it briefly about the use of umbilical artery Dopplers. We've talked about the frequency of testing, about 2 to 3 times per week if it's absent. And then if it's reversed, then you need to admit them for inpatient management. So I'm hoping that some of the patients that Dr. Blumenfeld mentioned were those who have abnormal Dopplers. If not, you could manage them as outpatients. Does not recommend the use of MCA or uterine artery Doppler, and does not even mention the CPR at all. Now, there are other comorbidities where the timing of delivery can be changed, from the SMFM document. I will show one of the slides next that shows some of these comorbidities. But if you have absent or abnormal umbilical artery Doppler greater than the 95th percentile, then they recommend delivery at 37 weeks. And for those with absent or reverse, it could be at 33, 34 weeks or less, depending on how abnormal the Doppler is. These are some of the other conditions that could change your timing of delivery, the other comorbidities in the mom that we should never forget about. So as we mentioned earlier on, it's really a kind of balance between stillbirth versus neonatal death and timing of delivery. And so there's a sweet spot that you need to try to determine for yourself as a clinician on when to draw the line and say it's time to end this pregnancy. This is the ISUO guideline for management, and it's very similar to most of what we've mentioned with SMFM, with the exception of the use of the computerized CTG, as well as the use of ductus venosus in timing of delivery, especially in early pregnancy. And then later on, I think I'll show the next slide that just shows you a combination or a table that compares these two guidelines, because those are the two that most of us talk about. Now, with SMFM document, it recommends delivery for an estimated fetal weight that's less than 10 percentile, but not below 3rd percentile, between 38 to 39 weeks. One question I get asked a lot when I give a talk on growth restriction is, what about now that we use abdominal circumference for timing of delivery? Should we also use it, as for diagnosis of growth restriction, should we use it for timing of delivery? And at what point? I think I have a study that just tried to look at that. We've talked about the absent or reversed and solid flow. SMFM suggests that you may want to consider doing a cesarean delivery in some of those cases. Obviously, try to give them steroids for long maturity and magnesium sulfate for neuroprotection. These things most people know about. So because of this question about should we use abdominal circumference if they are less than 3rd percentile and they are 10, should we deliver them the same way as we're delivering those with EFW? Our group kind of decided we would do it, we would treat the abdominal circumference in a way that's similar to the estimated fetal weight less than 3rd percentile. But this was not based on any strong evidence. Just saying, if SMFM is saying we should be using AC for making the diagnosis, maybe we should consider using it similar to EFW. But this is Alfred Abu-Hamad's group and Juliana. They both wrote the SMFM document. And because they got this question asked a lot, they looked at their own database and looking at over 700 patients with growth restriction. One group was EFW between the 3rd percentile and 9th percentile. So it was your traditional growth restriction, but not severe. Another group was just looking at those with AC less than the 3rd percentile only. And basically looking at some of the neonatal outcomes that most of us are interested in, including stillbirth and death before discharge in the NICU. They showed that the EFW appears to be a better predictor of adverse outcomes compared with just using AC only, but that the AC only less than the 3rd percentile was also associated with a moderate risk of adverse perinatal outcomes that were associated with. So basically, they're leaning towards saying we should use it the same way as the EFW for timing of delivery. But they've had a caveat there to say maybe we need some more studies before widespread adoption of using this. So that's one of the areas that needs to be studied. It's a good project for most fellows or residents if you have a database to look at that. So looking at SMFM and ISUOG, really this, if you look seriously, most of them, the guidelines are very similar. The only differences, like we've mentioned, are things like the use of the MCA Doppler and the ductus venosus, and then short-term variation from the computerized CTG. And then, if not, then also the middle cerebral artery on its own, not just CPL. So otherwise, most of the criteria are very similar. So I'm going to conclude here and then leave time for some questions and discussion. Basically, there's a lot of controversies that we've touched on very quickly on both the definition, the diagnosis, and management of growth restriction. Now, SMFM guideline is really trying to find a middle ground and also trying to protect some of our practitioners in the smaller hospitals where they don't have access to some of these sophisticated Dopplers that are used in Europe. But there's definitely need for more studies. Sadly, it's hard to do randomized controlled trials in these areas, but even large, well-designed observational studies could be helpful. So once again, thank you for inviting me, and I'll be happy to take any questions. Thank you.
Thank you so much, Tony. That was certainly a phenomenal presentation about the highlighting all the controversies that we feel on our body every day when we're AP rounding. I'd love to, I have a lot of questions, but I'd love to open it up to my colleagues first before I bombard you with my personal questions. It looks like Sana has a question. Can you comment on growth velocity or interval growth? And that was actually one of my questions. Well, maybe I'll just sharpen it a little bit. How do you handle absent growth over like a 2-week period? Like how much value do you put on that?
Yeah, actually, that's an area that I did not cover, but it is in the ISWA guideline, right? As a fall in the growth velocity, definitely. So it's suggested to be one criteria for making diagnosis of fetal growth restriction. One of my fellows also looked at that and is presenting that at SMFM this coming meeting. I believe that the growth velocity actually could be a better way, because it's almost like you plotting an individualized trajectory for that fetus, right? So I think it is a useful tool. The problem is most of us don't have strong guidelines. Some people will use fall below 1 percentile, below two standard deviations versus at what point. It's very rare to get to a point where you have absent growth. But when you get to that point of absent growth, I definitely would throw in the towel and, and consider delivery.
Yeah, thanks.
Tony,
Anybody?
I have a question. What do you think are some of the reasons why there is this divide between Europe and the US for what shouldn't be that hard a place to find common ground?
Yeah. I think part of the reason is that, first of all, I think the reason the Europeans think we're a little bit backward, it's partly, I don't know if we collaborate as well as they do, Many years ago, I think maybe 15 years ago, and maybe Yoel may remember this, some of us had a meeting at SMFM where we're trying to come together and design a study similar to what the Truffle group did. This was when Ahmed Bashat was very much into doctors venosus, and nobody else was using it in the States, right? So it looks like they have more collaboration without competition for finances or any reason. So they will send patients to one center, a regionalized center, and get more data easily. And they somehow have a way of doing their research in a very cheap way, which I was talking with Dr. Blumenfeld earlier on. Maybe partly they are not as cost conscious as we are. So they then generate maybe bigger data sets to show whether something is useful or not. Having said that, the protection of people in the remote regions of the US is also very important. So not everybody will be able to do a good doctor's venosus Doppler in a remote place of Missouri. So you want to make sure that you coming out guidelines that can be used everywhere and not put us into trouble. So I think that's part of the problem, but I don't think I have all of the answers to that, but yeah.
Yoel, I see you have your hand up.
Thank you, Tony. Great to listen to you again. It seems that some of the controversies regarding diagnosis and management are related to the fact that FGR is a syndrome, not a single disease. So how close are we to start stratifying our management based on the etiology of FGR and not just based on kind of cross-cutting guidelines?
Oh boy, that's well said, Yoel. As a scientist, that we know definitely that what's caused by placental origin versus what's caused by genetics is very different. And obviously, constitutional growth restriction is a whole different group as well. So you are right that that's part of the problem, in that we're trying to use one treatment for every cause of growth restriction, without specifying maybe something that's related to placenta, maybe a different cause and a different treatment, because you cannot treat the placenta, right? Or if it's due to some genetic syndrome that's really embedded within the fetus, we may not be able to alter that. I don't know of any study out there, any interventional study where they've tried to stratify fetuses or patients based on supposed etiology, But that would be a great intervention to do, to say, well, maybe aspirin may help some of those that have placenta origin, maybe, whereas there could be other things that you can do for other groups, which obviously I don't know the answers to the treatment for that. But I think that's one of the problems we have, just like with preeclampsia. Not every case is the same. Yeah.
Yeah, thank you. Any other questions?
Tony, I just, maybe not for this lecture, but when we bring you back, I'd love to throw in monochorionic pregnancies and growth restriction and abnormal Dopplers there.
Oh boy, yeah, definitely. That's a whole different group of
Yeah. Talk about abnormal European guidelines.
Oh, thank you so much. Yeah, no.
Tony, one quick question that I had, 10
Yeah.
years ago or so, there was a big focus on how reverse end diastolic flow is associated with stillbirth within a few days, right? We were kind of beaten into our heads that association.
Yeah.
And then all of a sudden, the recommendation with reverse flow is like 30 to 32 weeks. And we're seeing not an insignificant amount of cases of early onset FGR at 24, 25, 26 weeks with reverse flow that all of a sudden we're watching in a way that we weren't 10 years ago. How do you think about reverse end diastolic flow nowadays, given the guidelines compared to where we were 10 years ago, where oftentimes it was reverse flow, okay, deliver irrespective of the gestational age?
Yeah. But I think obviously we are learning a lot, and I think that's where the Europeans say they will use other Dopplers to refine the timing and not just go with the reversed flow. But you're right that sometimes when you have reverse flow, you want to make sure, first of all, the calibration of the machine on ultrasound done properly, But the truly reversed ones, we know that no matter what, if you deliver them too early, the gestational age is what trumps the growth restriction or the hypoxia that's caused by the reversed end diastolic flow. I think Ahmed Bashad showed clearly in one study that even irrespective of the Doppler changes, the gestational age at delivery, if it's too early, nothing you can do really helps that fetus. So the new policy of watching them more closely, I think, is conservative, but I think is still better in that we gain a few weeks to get some maturity, not just for the lungs, but other brain issues that could occur. So I think this is partly because we're learning more about the role and the use of Doppler, so that's where we're able to wait a little bit more. And the Europeans will even go further to say they wouldn't deliver until maybe the doctors, especially in those early gestational age, the doctors venosus is abnormal.
Yeah, thanks. All right, Tony, we kept you a little longer than you're being very generous with your time, and really thank you so much for joining us and presenting this. And we look forward to seeing you at future meetings, maybe at SMFM this year, and continuing to pick your brain periodically on this issue and many others.
Thank you so much. Thank you, Yereb, Dr. Blumenfeld, and everybody, and Syed and Sadowski. It was fun giving this talk, and look forward to seeing you guys soon. Okay.
Thank you so much, Tony.
You're welcome.
Bye-bye. Yeah.
Bye-bye.
Yeah.